All right, live stream and recording is up. Everything should be good to go. Best of luck, everyone, for the debate.
Once again, the motion is that we would allow doctors to override advanced care directives. Best of luck to everyone in the final. Let's start with the Prime Minister. It's Debayan. Here.
Hi, can you see and hear me? Cool. Starting in 3, 2, 1. I want to get two things clear at the top of this speech. First, I think on our side, this looks like completely removing the legal implications that exist with coming of this overriding. So what Negative has to defend is a world where taking this decision is still possible, but you risk things like penal consequences. So doctors are still not going to do that in most cases on their side. On our side, doctors just defer to their professional judgment when making this choice. That gives them a greater amount of autonomy to choose these things. Second, this debate doesn't only look like this. It looks like two kinds of people. It looks like people who in advance say that if they're faced with a terminal illness, they want to die. But it also looks like people who, when they are faced with a terminal illness, say that they want to live, and then the doctor makes a choice that they should not go through that treatment at one particular point of time. We're going to deal with both scenarios and then walk you through why doctors should be allowed to override them in both instances, because in both instances, people have different mind frames. Let's go straight into our first argument then. That is the argument of autonomy that Negative is just definitely going to run. I would just like to note that you should not have the autonomy. You only have autonomy to make choices when you have perfect information that exists. As a first and most important idea, that is to say, when you're making an advance care directive, you have absolutely no access to what you're going to think when you actually face that terminal illness within the future, right? There's two situations that once again come under this. I want to illustrate both of these very conclusively. Let's just go with the first one. The first is people who, when they're faced with any kind of suggestion that they might have a terminal illness, are people who just say, no, I don't want any treatment at that particular point of time. Please just stop giving me any kind of treatment. What is the mind frame that these kinds of people have? These people have the mind frame of denial. That is to say, when they're faced with an unpleasant situation within their life that is in the long term, you're likely to just deny it at that one particular point of time and refuse to think about it. This is for two reasons mainly. The first, you have stigma associated with these illnesses. That means you don't really want to think about this in a lot of detail. But secondly, you do not want to conceptualize what the implications of that terminal illness are going to be in the future, because of the fact that you've heard of a lot of pain associated with this. You might have a family member who struggled through this, for example. You might have seen it on TV, probably don't want to go through that pain in the first place, because you don't actually have to make that choice standing right there when you're diagnosed. You can make that choice relatively impartially, and we think that's a choice that's like filled with imperfect information, because you're not able to conceptualize it once you do so. But this changes at the point at which you actually have to make that decision, and it's a very simple reason for this. When you actually have to make that decision, you can't really go back to that life you had before. So you're probably going to have restrictions on what you can eat. You probably have restrictions on where you can travel, probably have restrictions on what you can do in your daily life. That's probably devastating and crushing for you. That means there's an immediate, pervasive change in your mindset, because your immediate autonomy to do things gets constrained. But there's also a counterbalance that you have to weigh at that particular point of time, because at that particular point of time, the prospect of dying comes with the prospect of losing your loved ones. It comes with the prospect of never talking to your mother again. It comes with the prospect of never talking to your kids again. It comes with the prospect of never being able to meet your friends again. It comes with the prospect of, for example, never having any kind of conversation with anyone you love. It comes with the prospect of you losing access to experiences you might have had. Those experiences might not always be uniformly good, but there's a chance you might live for a bit longer. There's a chance you might live for slightly longer. And this is where the doctor's judgment comes in, and this is where it's extremely crucial. We'll explain why doctors are well placed to make this decision in the first place, but doctors will only override these care directives if they know that there's a reasonable chance that the patient is going to feel better, patient is going to heal, or the patient might just actually get better in the long term in the first place. Which means that when we talk about all of these benefits on our side, it's actually likely for you to access those benefits, actually likely for you to get benefits and access to all of those things, which you're going to lose out on Negative completely because of a decision you made in the past where you don't have access to these preferences in the first place. That's the first kind of scenario because of that asymmetry of information. But there's a second kind of scenario as well. The scenario where when you're faced with this negative information, you have an extra positive reaction to it. You're like, okay, no matter what happens, I am a fighter and I'm going to fight against this, whatever terminal disease I continue to have, and I'm going to actually make my way through it. We're fine with this kind of thing, and we think the doctors are probably going to prefer this in most cases, as long as you come up into an extreme inflection point where there's no recovery point for the patient allowed. This might look like, for instance, the patient going into complete vegetative state and being in a coma permanently with very, very little chance of recovery, completely draining their family's resources, and their families to see that, like, the families to see someone that's very important part of their family just lying on the hospital bed, not being responsive, not saying anything day in, day out for months and for years. We think at that particular point of time, doctors will make the choice to override the care directive that you gave to them, because of the fact that if you have this extreme positive reaction to this one particular kind of thing, because you weren't able to actually perfectly conceptualize the implications of the fact that you might become a burden on your family, that you might not be able to get all those benefits that you think you would have gotten. Because because if you think that there's going to be some level of recovery when you make this decision, when that you don't actually conceptualize beyond that particular limit, you don't think about what happens when you go beyond the point of recovery as a whole. We think at that particular point of time, you should be able to step in and then just let's just say turn off the life support and then let that person die, because that is the one choice they would have made if they had access to that perfect information in the first place. But second, I just want to note, if they run the argument of autonomy, you don't have an opt-out mechanism or negative at all. That is to say, you make a decision that you made 20 years ago and you can never change that decision at all. If you want to make that change right now, but you're not able to do so because of the fact that you have a terminal illness, you're not allowed to make that choice. We give them that opt-out. Even if that opt-out isn't by that one particular individual, there's still a semblance of the opt-out because of the fact that the doctor can make the choice. You can still have the family giving some inputs as to what that person would particularly want. That's some relative level of opt-out that still provides some level of catharsis and some level of autonomy fulfillment on our side of the house as compared to the world of negative, where they don't allow them to change the decision at all. I don't think it's a complete part of autonomy in and of itself. But secondly, and very quickly, coming to the argument of why doctors are well placed to make this decision as opposed to any other actor in this round. First, no, this debate happens in Western liberal democracies. That is to say, you have large amounts of morality. You have common belief that you probably want to, let's say, respect decisions that people make, but you're also made to believe that you probably want to lessen the suffering that people continue to have. You're able to then balance both of those values out because you believe in, let's say, equal rights and human rights, etc., etc. You grow up in WLDs. But there's unique things about doctors that make them well placed to make this choice. Number one, you have an education. Let's just say that you probably have a Hippocratic oath and you probably have an education over multiple years or up to a decade that drills into you that you have to care about patient well-being. You have to care about patient preferences at the exact same time. So you're probably trained in a way, you're probably educated in a way that you can actually make those balances and make those choices. Second, you have the experience to deal with these matters. Not only have you seen patients who have gotten better, and not only are you in touch with patients who have gotten better from terminal illnesses and then continually thank you for the fact that they're actually a lot better and they're able to actually live life normally, you'll also meet families who suffer. You meet families who suffer day in, day out, who come to the hospital every single day to see their father, to see their child just on the ventilator and not being able to get up and suffering. Doctors can then make this, doctors are then well placed to actually know the emotions that exist. But the crucial tipping point is that doctors are well placed and can make the judgment of where this person is actually going to get better and then get access to both of these preferences because they know what both of these extremes generally tend to feel like. That's why doctors are just well placed to make this because of their education and their experience and the fact that they probably have a large amount of empathy that they've developed over time. Finally, then just a brief practical argument. Note the fact that on their side of the world, doctors are become a cog in the wheel. They, despite all of the human suffering that they see, despite all of the things that they see, despite the fact that this patient might get better and the fact that this patient does not take any kind of treatment, the doctor has to completely go through this process over and over again. The implication of this is that there are less doctors who probably want to opt into this in the very first place because overriding it has penal consequences. So you have less doctors who go into things like hospice care. You have less doctors going into things like the treatment for terminal illness are just generally practically bad for a lot of these people. We give more autonomy to people. We ensure that the best decision makers make that choice affirm.
Thank you to the Prime Minister for that speech. And now welcome the Leader of the Opposition to begin the case for side negative, University of Malaya 1. That's Ahsan. Here.
Sorry, am I visible?
Yeah, but you're echoing. So I think turn off the audio for another one of your computers.
Oh, okay, sorry. I think this should be much better. Am I still echoing?
Perfect now.
All right. Starting in 3, 2, 1. What is living? Is living decided by the number of heartbeats that your heart gives out? Is living decided by the number of people who mourn your death, perhaps? Inside Negative, we believe living is decided by you, especially in conditions where you're sick, incapacitated, and unable to no longer make decisions. We think that it's imperative for your decisions to be respected, especially by people who are supposed to be maximizing your ability to live your life at the end of the day. Couple of things I'm going to be doing in the side of First Negative. Number one, couple of responses to their side, particularly two, ultimately onto one piece of framing, and then onto two arguments. Two responses firstly. The core argument coming from them is on the autonomy to make choices, and they say they're only preserving this particular autonomy in instances when there's perfect information. The first thing that I want to note here, that in no decision that you make ever will you ever have perfect information. In all decisions that I make in my daily life, like, do I want to continue with the degree that I'm doing? Do I want to continue with debating and continue practicing so that I can make world champion one day? These are all instances which outcomes we don't have perfect information about. I don't necessarily understand why that's the only instance where you preserve the autonomy to make choices, especially when you don't have guarantee over that in your world as well. But they then say that individuals only make decisions as such when they are in a mind frame of denial, which means they deny and refuse to think about the illness because there's stigma oftentimes associated with these illnesses. The first thing I want to note here is that this is probably true if the illness isn't as bad yet. Understand that the debate operates on the context in which this disease or this particular illness has already incapacitated you, has already taken away your ability to make those decisions healthily. I would argue that people wouldn't be detached from the idea that they're sick if they have stage 4 cancer or they're highly incapacitated, but also grief or any form of sadness is a process, right? So even if it means individuals start off being in denial, I think they soon come to accept come to the terms that they do have this particular illness, that they do have cancer and things like that. But the second thing I want to respond to is on the fact that people lose the prospect or prospective benefits like talking to your mom or doing things that I enjoy in my life. I would say people consider all these aspects, but maybe not in the outcome that side affirmative posits. So it's not maybe the fact that I can talk to my mom is the benefit that I prioritize or that I want to maximize, but it's the fact that I maybe don't want my family to be in debt. I don't want my parents to be in medical debt to the point where even after I die, they're still stuck paying that debt and they're stuck in an eternal process of harm and actual concrete pain, right? But then what do we say then? Number one, what are the decisions people are likely to make in ACD? Understand these are illnesses that look like terminal illnesses like Alzheimer's and Parkinson's. In all these instances, your right to choose how you want to live your life is stripped away because your decision-making ability is severely hampered by the fact that you are sick. Number one, you probably can't move as much because of paralysis, which takes away your physical consent. You lose significant parts of your memory, which take away your control over your emotions. But it's also all the other decisions that we make on a daily basis, like what food I want to eat, when and where I want to go to the toilet, right? These are all decisions that people lose control over in your side when they are inherently sick. I think the stance on side negative would be protecting people and their decisions, especially in instances where they can't make those decisions anymore. These decisions are likely to look like do not resuscitate loss, organ donation, or like donating your body to science, or even euthanasia, right? The first argument then, why is it unjustified for a doctor to override this directive? And the prong here is on the imposition of medical ethics onto a patient. The ethics of all doctors is based off of the fundamental idea that life has to be preserved in all instances. Therefore, there are two key ethical principles I want to highlight here, and that's non-maleficent, which is that doctors can't cause harm to patients, but also beneficence, where doctors must provide the best treatment possible to patients. Preservation of an idea, a preservation of life then, is an idea that is abstract, because it's not just about maximizing the heartbeat or the number of days that this patient is particularly living, but will the preservation of their life guarantee one that is of quality? Because quality of life can only be decided by what a patient views a life of quality to be. This is why even with core principles mentioned above, the balancing principle in all these instances is always the autonomy of the patient. Why is this the case? Number one, patients have most information about themselves regarding their tolerance of pain, their priorities, their lifestyle. Doctors lack this epistemic access because you just can't know what this particular patient is thinking about. Why people have the most information of themselves? Firstly, in regards to pain, people know how much their tolerance to pain is and the suffering that they go through, which means if I make the decision and I say I do not want to be resuscitated in this particular event, that means I know myself that I can't tolerate this pain. But if I do make the decision that I want to fight, but the doctor's decision is one that clashes with that, we think that there's one that's unjustified either, because if I feel like I have the ability, the physical and emotional strength to go through this particular illness, I should have that ability. But secondly, in terms of livelihood, people know what capacity they want to people know to what capacity they want to live their lives. Like, what would the conditions of a life that would be meaningful be to them? Like, if I had quadriplegia and I'm like a mountain climber or something, that isn't a quality of life that's meaningful to me. I think it's fair for people to opt out of a life that they no longer view of quality and one that's meaningful. But secondly, here, the patient has most likely exhausted all alternatives before making this decision. Why is this true? Number one is that this is a matter of life and death. In all instances where it involves sustaining or foregoing your life, it's a huge decision that you want to make. And it's also important to know there's an inherent nature of humans to sustain their life. Therefore, if individuals in our world make the decision to opt out of life or to give up life as a whole, we think that that's a decision that's fair and has been thought out properly. But it's also the process behind this particular directive that warrants pre-planning, because this Advance Care Directive requires you to probably meet your attorneys, get validation of different stakeholders, and like approve your will and things like that. But thirdly, it's also family consultation. You probably have discussed this with your family members and other people who you probably have involved in your life. We think that this is a decision that are going to be made out quite well thought out. What principles do we then preserve? Firstly, is autonomy to patients. Why does healthcare care about this? Because when you're in the business of preserving human dignity, autonomy is probably the most important part of your dignity. It is the fact that we are able to choose what we want to do with our life, and the decisions that we make on a daily basis is the greatest depiction and the greatest show of our ability to be humans. That's why even in instances where vaccines have an objective good towards humanity, we still don't force it onto different stakeholders who don't probably want to opt into it. But secondly is the decentralization of medical science. Medical science awards a decentralized ability for people to make decisions for themselves. That's why we have things like self-diagnosis websites like WebMD, or we have over-the-counter medication in pharmacies where individuals can go and buy medication for illnesses which they feel this would be the right treatment. Even if this decision is made under distress and is one without consent, and like all the bad stuff that side affirmative talks about, all decisions that you make in your life are ones that are unaware of the outcome. And this is something that I already talked to you earlier. It's unjustified that you're policing people and using this as a reason to make this decision. But secondly, patients are probably even more sick in your world and can't be rational because of this sickness. The fact that I have Alzheimer's and I forget how my daughter looks like, these are things that impair people's decision-making ability. And I think it's much better that people make these decisions prior to them or prior to the illness having this bad of an outcome. But thirdly, you can never guarantee that the doctor is making the best decision for this patient either. They said on your side that you probably have an education and experience, and that experience is probably going to grant you an ability to empathize. I would contest that, because if you're seeing suffering and pain on a daily basis, if you're a doctor, you're more likely to be desensitized towards this pain. I would argue doctors would probably be more okay with seeing this patient die. But secondly, then on a practical, firstly on the quality of life, why going by the ACD maximizes quality of life? In the worst case, there is treatment for you, but you do not take it and you die. In the mind of the patient, this is okay because you did not know that there was a better treatment to begin with in the first place. This is the best decision that you have made from the perspective of the patient. This is the perspective that matters the most. But secondly, this decision is weighed in according to unique circumstances of the patient and the family, and that is to maximize the prevention of negative externalities. Things like going into debt, things like insulating myself against the trauma and pain. Because in instances where patient has already made this decision, the family is already ready for the worst case possible, that, okay, this is the outcome that I have to be prepared for if my particular loved one dies. But second, you're setting a harmful precedence for overriding patients' rights. The precedence that you're setting in your world is that it's okay for doctors to override the want of the patient. And this is the core tenet of things like denying access to abortion, or how people of color are being denied access to medical care. The comparative is here. There's a higher prospect of guilt inside of affirmative. In this individual's life, when they're alive but really impaired, is a guilt and continuous pain that makes them want to give up even more, which means you push individuals to the point of depression, where because they didn't have an ability to decide how their life would turn out, they feel worse about themselves. But you maximize negative externalities on your side. You push more families into debt. You push more families into the worst corners of grief, where they cannot deal with the fact that they're going to lose their loved ones soon. We prepare families more for those outcomes. We fight for the patient and for everyone who matters.
Thank you to the Leader of the Opposition for that speech. And now welcome the Deputy Prime Minister to continue the case for Mumbai 1. Here.
All right, hi. Can you hear me? All right, just give me like 5 seconds. All right. Starting my speech in 3, 2, 1. The reason why this scenario is different from any other scenarios that you would essentially deal with is because this is one that deals with terminal illness. This is something that deals point at which, I mean, you perhaps have no other opt out because you're literally on that deathbed, or essentially you're in the last dying moments of your life. This is not similar to, say, for example, you opting in for a debate tournament because you perhaps can opt out at any other point of time, or choose that this activity isn't worth all that effort and you can essentially move into another activity. Or whether it be, say, for example, you regret, say, for example, a degree that you did previously that you feel is no longer relevant, but you can always choose to opt into another degree and then maximize your choices. The problem, the scenario why this is unique is because this essentially, like, you're literally in the dying moments of your life. You're literally, in this instance, the very last moments that you can experience as an individual. That is the reason why this is a very specific context and not like any generic context that side negative wants to push the burden. We think like that response was largely inefficient. Firstly, I'm going to deal with in terms of why your ability to make future preferences and what this individual is in a situation with, and why you should give them the opportunity, and then pragmatic arguments in terms of why this undermines trust in the system. Firstly, in terms of their ability to choose, the response that I get from largely from side negative is to say that at this particular instance, you perhaps have like no option to essentially make those decisions, or say, for example, you could essentially make that decision previously in the past. They never prove in their arguments in terms of why you are in the best possible situation to make those decisions in the past. Because I think information asymmetry is an important thing, because the way like society largely functions around, we largely delegate responsibility to individuals who have a larger sense of information about circumstances. That's why we allow parents to make decisions for their children, because they have greater amount of like access to knowledge to essentially determine in terms of what would be the best outcome. That's why we delegate responsibility to governments to make essentially decisions for individuals and citizens, because they have a greater access to information that normal people don't. We think that premise is still correct because they haven't essentially challenged that, because the point at which you have greater amount of information, that is where the choice should be better placed, is essentially the argument that we make on our side. That point at which when doctors essentially have a greater amount of experience to deal with those scenarios in terms of how to, say, for example, deal when you have a life-threatening illness, whether to continue the life support or not, make the best possible assessment at that particular instance. We think at that point of time, it's principally justified to delegate responsibility to doctors because of their experience, because of the commitment that they have essentially to the job. It's not about whether they're sensitized or desensitized, because that's a claim that they can't prove in their speeches, because that's like subjective. But the very fact you have comparatively more amount of experience to essentially save that individual, or essentially, say, for example, to do in terms of what the best scenario is at that particular instance, is something that's rather objective. But secondly, we're going to contend that point at which when you make this decision and make this a legal document, you lock this in, which means that in a best case scenario, when, say, for example, it's done 10, 20 years before, you didn't have access to your future preferences in terms of what happens. Perhaps your financial condition improves over time that you felt that you want, like point at which they feel that you can be in debt. That could be a scenario 10 years before, but perhaps after 10 years, when actually that scenario happens, that circumstance that you face as an individual is no longer valid. But secondly, we also feel that individuals largely change their preferences over time. You can never lock in preferences. I think that's unintuitive. That's why individuals say switch between jobs, switch between educational degrees, switch between things that they want to do in life, or switch food preferences, switch a lot of things, which means individuals always adapt to present circumstances to essentially dictate in terms of where their life goes forward, which means you always should have the epistemic access to determine things in present and not essentially lock yourself out of the scenario in the past. This is something that's important, because point at which we feel now when you lock this legal document in, it's very difficult for you to ever change it at any point of time at a future, because at this point of time those preferences are locked in. We would comparatively argue that you have greater amount of epistemic access to preferences in the present that you ever had to preferences in the past, which means we think that the patient, and we don't think that at that point of time in those dying moments you essentially have zero amount of autonomy to decide in terms of what happens, or like zero amount of autonomy to decide in terms of what you want as catharsis in the last moment. Even if you have less amount and very less amount of autonomy, you still should be able to decide in terms of like how essentially you want your life to end, or essentially what you want in those dying moments, whether you want the life support to be continued or not, whether you essentially want to meet your family for one final time, or essentially you want to like prolong that treatment or not. We think at that point of time you still should have the ability to do so. The reason why in that particular instance you should essentially have the ability to do so is because at that point of time we think catharsis is incredibly important for individuals in those dying moments. Essentially, point at which when you lock yourself out at a previous point of time in history, I think at that point of time, it creates more amount of regret, because in those dying moments where you needed the catharsis the most, you could no longer exercise autonomy as an individual. I think that's a more harrowing experience, because at the end of the day, then you feel that in those dying moments and in those essentially last possible moments, you were helpless and you were essentially locked out of your own self. We think that is more harrowing, and that's the reason why we think it should not be something that's locked away in the past, and you should be able to take advice from your doctors, take advice from your parents, and essentially take advice literally from the people who would know the situation the best than, say, for example, locking this up in the past. But secondly, I think in terms of doctors having greater access to in terms of things largely general, we think it's not about the case in terms of whether you're stigmatized or destigmatized, because that's largely subjective to prove. Rather, what's objective is that in terms of individuals, like doctors' commitments to essentially save lives, or the very fact that you had an education, or you essentially took that Hippocratic oath, or you essentially had that experience to determine in terms of what would be the best in terms of parents, like in terms of the patients in that particular instance. Essentially, we think at that point of time, given the fact that they would have greater access to that information, whether, like, say, for example, if you thought that your life could not be saved at all because, say, for example, it would cost incredibly huge, and on that like premise you made that decision, but now essentially you are in a situation where perhaps it's not that cost ineffective and the doctor can essentially save you. I think at that point of time, the doctor should have had the decision, like, can override it or essentially make that choice for that patient at that point of time. We think at that point it would greatly maximize the benefit. But lastly, in terms of why this undermines like medical profession as a whole and then prevents also medical research, etc. Firstly, I think you greatly reduce the quality of healthcare the doctors would give in general, and this is like a pragmatic argument independent of any principle, because point at which the reason why you opt into a profession, because you feel that you can make a difference in that job, you feel that you can exercise your autonomy as an individual, you can maximize benefits for the other person that you're essentially doing for, you can essentially make the best out of your job, and you essentially are not constrained by other factors. Point at which when doctors know that they can never override this and they always are constrained by this, like other individuals' choices, at that point of time their ability to fully autonomize themselves or essentially make the best possible outcome, or even, say, for example, have that inspiration, like aspiration to opt into that ability, that they opt into that profession that they can actually make a difference in, greatly reduces, which means you have less individuals giving quality healthcare, you have less individuals opting into the medical profession, you have less individuals opting into these things, which is in general the quality of healthcare largely reduces when individuals are rather antithetical or essentially are feel the sense of dissonance when they want to opt into this profession in the first place. But lastly, then I think this also greatly reduces the amount of medical care that you can do, because like most of medical research takes place on terminally ill patients in terms of what happens in these particular circumstances, or, say, for example, the experiences or scenarios that largely pan out in these scenarios. I think at that point of time, it's also very difficult to ascertain these things. Lastly, I think at the end, the conclusion is pretty simple. You cannot essentially you cannot determine your preferences largely in the past. Preferences change across a period of time, which means at that point, there are two things that largely happen. One, you either delegate this to the person who has greater amount of information to make this choice at that particular instance, or you should still preserve the autonomy yourself as an individual to make that choice in present, to have that final catharsis and ensure in terms of how at present you determine in terms of what trajectory your life should take. For all those reasons,
I thank the Deputy Prime Minister for that speech and welcome the Deputy Leader of the Opposition to continue the case for Malaya 1. Here.
Visible and audible? Okay.
Yep.
Starting my speech in 3, 2, 1. Panel, there are individuals in this world that are born straddled to their graves. What does this mean? From the second they were born, they were preconditioned towards situations in which they are going through immense amount of pain, debilitating situations where their disease is killing them. And it's only worst if the doctor makes a decision that is not only not qualified, but not the best decision to make at that point of time, that hurts the quality of this patient, that goes against every single principle that we ought to prioritize in medical science, and more importantly, causes the doctor to go through more worse forms of exploitation that hurts most vulnerable individuals. That's why we're incredibly proud to negate. Three questions I'm going to answer in this speech. Firstly, is this justified? Secondly, how this worsens the precedence of doctors abusing the rights of patients? And thirdly, which side preserves the quality of patients? All responses will be integrated within this question. But firstly, I want to point out is in terms of the groundwork of this debate, what is part of this debate and what is not. Two things to note here. Number one, the speaker before me asserts that ACD is taken during dying moments. But we already was very clear that this is not the case all the point in time, because ACD is oftentimes taken in a situation where you're not in pain yet, where you're possibly going to go through pain, where your disease is probably going to worsen or be more debilitating across a period of time later on. That means you, to a large extent, are mentally sound and physically able to make the decision. Why is this the case? ACD oftentimes have a very intensive process of you getting things like durable signing off power by attorneys, or getting validation of different forms of specialists like psychologists, or even going through family consultation. All of this is a rigid process that goes by way of ACDs. I'm unclear why their metric is correct that it's only through dying moments. So this preliminary establishment is already proving why affirmative team is not dealing with instances where people can consent and make decisions, and why that's not the case. We'll also explain why even in the case that is dying moments is still fair according to medical science and the principles they ought to prioritize. Secondly, even if doctors have greater experience, their assessment might be wrong. It might hurt the quality of life of patient. I'll do the weighing as to explaining why we can't go against the medical science and practices that we have principally, but more importantly, even in the worst case that this patient is dying or this patient is a worst off position, the fact that they consent to that choice is one that would likely manifest in the quality of life of a patient being better, and that is already a better form of weighing. First question then, is this justified? We need to note that the core tenets of medical science has to be balanced out towards the respect of autonomy. We were very clear from first to explain why the principles of non-maleficence, which means medical practitioners ought to not cause harm, or beneficence, which is that medical practitioners ought to give the best treatment towards patients, oftentimes have to be balanced out towards the principle of autonomy. That is precisely the practice that we've been practicing in the status quo. The fact of the matter is, doctors can't impose a Jehovah's Witness patient to get through blood transfusion, even if it's life-threatening, because it's their right and their say and their will to go by their life. Because you can't make an objective decision to think that if I go through a blood transfusion, my life would not be like, I would be causing a sin to God, and that would not be a quality of life in my eyes as well. So doctor can't make their own scientific definition of what life is, as opposed to a happiness and holistic assessment that a patient is likely to make. That's why you also can't force someone to take an abortion, even if going through the pregnancy is incredibly complicated or might go through a mother's life. This is important because I don't see the exception towards why we have to overthrow all the medical ethics and practices that we have that give back autonomy towards patient. What do patients know? Two things. Number one, they know the measurement of adversity right now. They viscerally feel the pain and debilitating state that they're going through. Doctors can't have epistemic access towards this. But number two, they know the sustainability of livelihood, and this is important. So independent of whether you live or don't live, the quality of life after that, whether or not you're in pain, whether or not your family has money as a result of paying that surgery, all these things are sustainable metrics to deal with the quality of living that patients oftentimes know. What did affirmative team contend? Number one, they say patients have a denial mindset. They'll just reject treatment. This is where they're incredibly uncharitable judge, because we also have the catharsis for individuals to internalize this. Why? Because we'll have advice for medical practitioners to say what this disease entails and how bad it's going to be. But time could also override the stigma, because oftentimes individuals are bombarded with a statement that says, I have stage 4 cancer. Everyone will ask, why me in the first second? But you can still research online. You can find support groups of people who are similarly like you. You can have multiple consultations with various doctors. What it means, you have time to digest. There's still catharsis for individuals to actually acknowledge. But their judgment then was to say there's some individuals that fight no matter what. At least right now, doctors can make this judgment and give the autonomy back to patient. Hang on, you're not respecting the autonomy if the patient's autonomy to begin with was to fight no matter what. So I'm unclear what the respecting of autonomy is if you're superseding this decision. So judge, this has been messy, but how do we resolve this clash?
Affirmative team can only win this debate if doctors make the best decision at all time. But 3 contentions from us that really push this back. Number 1, on cost. Even if doctors are best equipped to make the decision, whether or not this treatment is something individuals can access is what we would question. What if you're poor? What if you don't have amount of money? What if your savings of your family goes to the sustainability of savings for their family and not towards something related to a medical health? This is important because if patients do not have the cost, you don't accommodate to why doctors actually make the best decisions all the time. Number 2, medical science has lacuna as well and make mistakes. That's why Vioxx, when it had so much of clinical trials that was on shelf, later on when they redid a new clinical trial, proved their side effects and we reverted. This is important because medical science can still make mistakes and therefore they revert on the decisions. It is untrue to say doctors make the best decisions, especially in circumstances of medical science. It's not always correct. But thirdly, science doesn't always have uniformity. Look at vaccinations. We have the best scientists and best doctors, but no one can agree what's the best vaccine in of itself. What this means is that oftentimes there's not the objective good that science can have and can portray. What this means is that at least we give the ultimatum back to its patient. We give them as much information as possible, which is what we happen in status quo, advise them on what the risks are, but then the ultimatum is back to these individuals. That's why individuals can still seek alternative treatment even if the doctor advised them on something, because the ultimatum is back given the lacuna to explain on science. This is significantly important because affirmative need to explain why doctors still are the best. Second, how this worsens the precedence of doctors abusing the rights of patients. We need to note that in the 21st century, doctors might not have the best interest of patients at hand. Why is this the case? 3 reasons why. Doctors oftentimes maybe don't care about preserving lives, but they are influenced by the decisions of the hospital and their respective clinics. This is true because oftentimes big pharma prioritize profit. So maybe you care what hospitals want, what operations are less costly for the hospital, not one that is best interest of patient. That's why doctors can say you have only 3 months to live, but maybe you have 10 years or a few years left because they want you to pursue alternative treatments or treatments that is more profitable to them. Number 2, that's what happened in status quo. Look at the death of multiple people in the opioid epidemic in the US, like how doctors were prescribing drugs like oxytocin or Xanax in high dosages and amounts that were so wrong as a result of lobbying of pharmaceutical companies. It's also the case that doctors don't know what's best. But thirdly, their metric of education experience is uncertain because that isn't how doctors and hospitals work in the present. That's not transferable to its real life circumstance. There's huge ethical decision. So in the worst case, an affirmative team, you're now setting a precedent of doctors now abusing or going against the rights of patient, forcing you go to practices that goes against their moral and dignity. I would argue that's bad for doctors. So you're going to get lawsuits. Even if they're able to frame lawsuits against ACD, you're more likely to get lawsuits as a result of setting the precedents of exploiting the rights of patients. So it's undue presence that doctors will go through. But at least on our side, finally, how do we preserve the quality of life of patients? That is the most important way. Even if the case that this patient dies out, that he took a do not resuscitate treatment request, but there's a better chance for them to live. At least in the mind of the patient, that's the best decision that you have right now. You're able to insulate yourself from the adversity. But more importantly, it's weighed according to unique circumstances. The fact that you probably have money, your parents prepared for the worst form of trauma because they know you're going to die. At least if you go through some treatment that's going to be worse off later on by listening to the doctor, it's going to revert all of the trauma they're going through. It's going to cost so much money, and that's not something that you were prepared to in the begin with. So at least in our side, we don't go through the prospect of guilt to it. It's living an impaired life where you're going to continuous pain because the doctor consented, not something that you want. And you go through the externalities of cost, resources, because all of these things, something the doctor imposed on you. To the very least, even if it's something that's consented for, it's something you want. We're giving the onus back to vulnerable patients to decide themselves, especially when doctors don't make the best decisions. We insulate themselves from worse exploitation and we preserve the quality of patients. So proud to negate.
I thank the Deputy Leader of the Opposition for that speech and now welcome the final substantive speaker of side government, the Government Whip. Here.
Hi, am I clearly audible? Good. All right. Starting in 3, 2, 1. Before I jump into our case and why we stand to win on why doctors want to opt into the profession and why medical science as a whole goes down on the pragmatics, I just want to defeat the idea of consent that they push from the first speech. And this is something I will defeat on 3 levels. Number 1, I think firstly, when you have already gone to a doctor and when you've already gone ahead and told them that, you have to deal with me, but deal with me in this way, I think the first step of you going to a doctor in the first place already gives a part of your consent to the doctor to decide what is good for you. And because you have gone to an expert for consultation, you're not going ahead and making, operating on yourself, or you're not going taking medications for yourself. You're rather going to a consultant or a doctor in the first place. So you're already given part of your consent when you choose to go to an expert in the first place. But even if you don't agree with that, there are two reasons why the consent and autonomy that they want to preserve on their side never actualizes in the first place. Number one, I think this is something that you push from first speech onwards, that you never have perfect knowledge of the kind of conditions that change. Saying yes in status quo in right now in this moment doesn't mean I'll say yes to the same things 10 years down the line or 20 years down the line, because situations change, preferences change. I might be poor right now, but I might just strike gold for that matter, right? And I might have the ability to go ahead and pay off the hospital loans. I'm not really sure why every time you will go into debt, and why every time everyone will just like be financially like not have the ability to go ahead and solve the problems or solve the debt in the first place. Perfect knowledge is never available to you currently, and this is the two reasons for this. Number one, because situations can change and there's like asymmetry of information that exists, because at that point when you're on your deathbed, when you have a terminal illness, the people around you, say the doctors or your family members, have better knowledge of your financial conditions and the better knowledge of what they expect from this particular situation, as opposed to you yourself, because you never conceptualize the idea of this terminal illness in the first place. I think feelings, for that matter, or your decision that you will take currently on the feelings, or like the conditions you will take probably will based on feelings for that matter, and feelings are always fleeting and can't be rationalized to yourself because you don't have epistemic access to your own self 10 years down the 10 years past, right? And secondly, I think they say that, okay, you know the pain, you know how much pain you can go through. I think since you have never entered the disease to the stage where you are terminally ill, since you don't have stage 4 cancer right now, you probably can't even conceptualize the amount of pain you'll feel in the first place. This means that you want to go ahead and you probably will never have the perfect knowledge to make decisions or allow the consent to exist in the first place. But second, and this is the more important bit, I think when consent exists, consent can only be materialized actually, or consent only is meaningful when you have the ability to opt out of that consent in the first place. That's literally 50% of how consent works, right? If you don't have the ability to opt out and you're forced into situations because, say, consent, I think the ability to opt out becomes immensely bad and immensely harmful for you, because it turns into things like regret. You later tend to regret that I might have made, I should have made a decision which was better for me. My financial conditions are not too sound. So because this debate does not exist only for those people who are likely to just say that I want to die. What if someone is like feels that, oh, my family should support me as much as possible, but at a point in time when my family is not able to support me, it's 10 years down the line, I think I'll just go ahead and regret that I'm putting so much burden on my family because I had imperfect knowledge and the situations have changed. I think to that extent, opt-out becomes immensely impossible on their side, because this person has no degree of autonomy when they're on their deathbed, and at that point of time, it becomes bad because consent gets violated to that extent also. So I don't think to what extent do they preserve consent, because if you're going to give them consent to opt in the first stage, I think you should also give them the consent to opt out at that point. So at this point, we say that don't make these people, don't give the platform for these people to make choices in the first place itself. You're going to bite the bullet and take the highest burden here, right? Sure, never don't give these people the ability to go and decide what's good for them in the first place at all. Why? Because the people around you have better knowledge. People around you are more competent to make a decision for you. This looks like doctors who are medical professionals who have literally worked their lives off to just get into this profession in the first place. Probably like they've done 2 degrees, MBBS and MD, to reach this particular position. But secondly, you already taken the Hippocratic oath. You already believe what you already want to do good for the patients. I don't think they can debate this motion on fringe instances of racism and where like doctors are just absolute capitalistic people who just want to gain as much money out of you as possible. I don't think that's a realistic scenario where they can do this motion on, because that's a totally different debate to be had in the first place, right? I think to that extent, you want to give the ability to decide to the people who are like in a better position, better place spot in status quo than you are. One, doctors. Second, your family members also, right? I think they say that your family will want to like keep you alive, and that's why they'll probably keep on paying, right? I think the families are in and of themselves, and this is how people perceive death to be, because it's so final, because they know that they will lose you. I think they just save you because they want their own objective to be fulfilled, which is they don't want to see a life without you. I think they don't do it just for your preferences, they rather do it for their preferences, because they don't want to lose you as a person, and because you don't know what you mean to them, and that's why they go ahead and keep on paying for people. I don't think it's as simple as preserving that this person should not die. I think what you gain gain out of this person not dying is why families opted into paying debt or opted into paying medical bills, primarily because of what you mean to them. I think if you don't go ahead and give the ability to the family to even decide anything for you at that point, the immense amounts of regret or the immense amounts of just breakdown of that particular relationship that I will have with someone who didn't even let me go ahead and make my choices as a family member who is seeing like other person dying is immensely harmful, because on the deathbed you probably will be left with sour memories. You'll probably be left with a sour taste in the mouth that I could not do what I felt was best for the person who was dying. I think to that extent, even when you can't go ahead and change your decisions, I think that also means that your catharsis on your deathbed, your regret on your deathbed also gets immensely worse on their side of the house. Now, they say doctors can't make decisions because there's debt and everything. I think doctors and family members literally consult with each other before taking a particular decision. So if you are not in a financially well-off state, you can probably go ahead and not take a decision to that extent. I think this is where we take that the preferences of the person who is in better knowledge condition or like is in a better place to make decisions or has more knowledge should matter more than this person who is literally dying, because this person can't go ahead and even opt out of this particular thing in the first place. But secondly, they say medical science make mistakes. I think if you don't allow the platform to exist, mistakes can never happen, and there probably will be no rectification of those mistakes in the first place. If you allow this precedent to be created, that I will just go ahead and just write everything off primarily because I don't want to put a financial drain on my family, and everyone just wants to die at that point whenever they're hit with terminal illness. I think the willpower goes out for the medical industry to even research for these things in the first place. I think that then it becomes exceptionally harmful for those people who actually want to live, who actually want to fight in the first place. I think the ability for you to go ahead and give them a larger pool of people to even try this thing, try medical research on is exceptionally harmful. It goes on their side of the house. And then they say science never has consensus and doctors have profit intentions. I think that both of things are extremely fringe cases, and sciences always have one common intention underlying the preferences or underlying the debates, which is to preserve life in the first place. I think the preservation of life becomes the most important on our side of the house, and that is why we stand to win this debate, right? What do we do uniquely on our side which is never engaged with through two speeches? Number one, we tell you that when you feel complacent as a doctor of this person's death, I think that immensely brings about a lot of guilt in yourself, because you know that you could have done something to save this person's life, but you couldn't because this person who has imperfect knowledge, who literally can't opt out, has literally put by or locked this in 10 years down the line, 10 years before you. I think this exceptionally means that the regret or the catharsis you get from the job also goes down. That means opting into the medical industry also as a consequence goes down. I think the complacency you feel from the debt also prevents you from literally functioning in society or functioning to the best degree in the medical sphere itself, right? I mean, research just goes on in the sector, and doctors generally are deceiving the system at that point. You feel that you're just a cog in the wheel, and you don't actually have the ability to save the patient in the first place, who came to you, and at that point, you felt that you were the better for you. You allow those things to happen primarily because you know that there's an information asymmetry. I think this is exactly why doctors should be able to have the ability to make decisions for you and not you yourself because you're imperfect knowledge. For all those reasons. Go.
Thank you to the government whip for that speech. And to finish off the substantive portion of this ESL final, the opposition whip. Catherine, you're here.
Hello, can I be seen and heard? All right, thank you. All right, starting my speech in 3, 2, 1. Panel, I plan to die by 60. It's not because I feel edgy and I feel like I only want to live in my youth, but it's because I despise being old. I despise the idea that I will not be able to move my limbs to the way in which I want to. I despise the idea of forgetting things and being weak and being dependent on another individual. Nothing will change that. And that is the most important contention coming from outside the house, that whatever doctors are trained to do in whatever capacity that they have, they can never make a decision as to what the quality of life of this individual should be. There are 2 questions in my speech I'm going to answer. The first, which side protects the best interest of the patient, and the second, which side protects the best interest of medical professionals to the largest extent possible. The first, on the best interest of the patient. The first thing I want to contest is on autonomy. F tells you that decision-making of a doctor is much more better. A few responses to this. I think firstly, even in the best case scenario, doctors are likely to focus on statistics, precedents, and hypotheticals because it is a science and it is a business at the end of the day. All of this just means that whatever decision-making that F takes on or what F laws to be the best is likely to be one that is dehumanizing in nature. Second response, doctors have many other considerations as well. Even if they're acting in the best interest of the patient, they have to expend this best interest to a lot of other patients that they have in their care. This means that they have to consider the financial benefit that the hospital derives from this patient, or the beneficial statistic that a hospital has as to whether they're able to have some groundbreaking treatment that is able to bring a patient from the brink of death back to life. All of this just means that this isn't necessarily true that whatever good decision that a doctor makes is likely to be one that is beneficial, or at least in the best interest of the patient. But third response, even when you are physically able, I think doctors always take an advisory position. So everything that the whip said on how consultation is one that you give up consent or you allow the doctor to make a decision for you is just really not true, right? Consultation is one in which you are able to take advice and then act on that advice to the best of your understanding and to the best of your needs at once. This happens the same in the legal profession as well, where you take legal advice, but that doesn't mean that you give up all your rights to your lawyer. Let's look at the second response that they had. They said that your consent to opt-ins means that you're able to consent to opt out. But I don't know why this is a problem in this debate, given that ACDs can be changed if you access the correct procedure to do this. But this is secondly, all of the arguments for why autonomy and consent is important just doesn't make sense, right? Because if you have the consent to opt in, that doesn't necessarily mean that the choice at which you make to opt out, which is when they framed this to be on their deathbed, etc., is likely to be the right choice. All of their harms were why you're not in the right frame of mind to make the decision, especially if they are saying that you're opting out when you're on your deathbed or when you feel like there is some life-saving procedure that's able to change your life in an instant, but is then unable to do so, means that all their benefits are speculative. What is the comparative then? I think you're likely making the right choice because firstly, you have the knowledge of what you desire in your life. And also secondly, you're likely to take in other factors like the sustainability of your family, the long-term implications of your family having to care over you if this medicine is one that isn't miraculous and is able to completely reverse your disease, right? Even if you don't have the best or perfect information at hand, why do you think this is still preferable? I think firstly, given that individuals act on whatever information they have, this doesn't change the desire of their outcome, right? But secondly, it also doesn't dislodge your right to make a decision. Two metrics to consider, panel. The first on vulnerability. I think we've proven to you from the beginning that we always have to protect the dignity of individuals. If they're unable to make the decision, we are supposed to honor this as much as possible. But also proximity. We honor the choice of decision, we honor the decision of the person that is most proximate to this issue, which in this case is obviously the patient rather than the doctor. Second part to this first question is on past versus present preferences. I think this is funny because all of their arguments about how you're on your deathbed and then act on present preferences is self-defeating, given that all their arguments about how you're not in the right frame of mind, you're likely to face a large amount of distress, is just there, right? But this is secondly, do we prioritize past or present preferences when it comes to making decisions about your life? I think in this instance, and when this debate takes place, the past is inherently better because you're obviously in a better situation. If you decide that you do not want to ever be resuscitated, you're obviously able to have more time to make the decision and more resources to expend in the making of this decision. But also compared to their benefits, it is likely to be very speculative in nature, because note that their benefit doesn't comparatively or at least guarantee that your life is going to be much better after you receive treatment from your doctor. It is also dependent on you likely having access to this medicine, which is firstly unlikely because I don't think science is able to develop that much. But also secondly, you're unlikely to have the financial resources to be sustainably on this medicine if it is not a one-off treatment, right? The third part to this, living with the override, suffering and guilt. They said in their best case, the doctor makes a decision and they live, and you are able to not, and you don't live, right? You live with guilt. But I think firstly, when it comes to an ACD, families most likely already know that you have an ACD in mind and already prepared for this. But also secondly, the importance of protecting the sanctity of decision that is made in the best capacity of this individual, I think is one that is more important. On the flip side, I think you're more likely to feel more suffering and guilt if you, as a person, is draining the resources of your family, trying to continue living, even if because the doctor keeps pushing you to live, right? Second part to my speech, which side protects the best interests of medical professions? Let's talk about legal implications first. F asserts that you're able to remove all legal implications. I'll contest this. Maybe you don't suffer any legal implications from the hospital, But obviously, there's going to be a personal claim from the family or from this individual itself, because the ACD is one that is a legal document. This is supposed to be something where in which your decision is protected, but the doctor decided to override that. But this is secondly, I think even if there are no legal implications, I think there's going to be a large amount of guilt. So I'm flipping the guilt argument for team affirmative. There's likely to be a large amount of guilt when you see this patient comatose, or there's likely to be guilt seen from the family suffer, right? When they see false hope, when the doctor tells you, look, this treatment can work, but it doesn't work to the best of its ability, right? When this patient is undergoing like experimental drugs and it fucks up their system in some way, or this patient isn't living to the best quality of life possible, when they are unable to walk, when they're unable to talk normally. I think all of this means that there's likely to be a larger amount of guilt that spans over a larger amount of time as compared to the short-term like guilt that affirmative contest doctors will face. But let's look at the long-term career of these doctors, right? I want to contest the idea that doctors are perfect bona fide actors, right? Because note that whatever affirmative says that if the doctors have to follow the ACD at whatever instance, there'll be cogs in a machine, they're already part of the machine regardless. Note that doctors are a career, right? They are part of a hospital that maximizes profit as much as possible. Even if you're in a government hospital, I'll argue that government hospitals would have to maximize some level of positive statistics to show that the healthcare of the country is one on a correct trajectory, right? But this is secondly, I think in status quo, we see doctors pushing medicines based on commissions that they get from being able to sell a particular medicine. I think we see doctors being profit-oriented on their own capacity. All of this just means that all of their argument, analysis that depends on the idea that doctors are able to make the best decision is one that is speculative and is dependent on each individual doctor. I've already proven to you why this is applied to a majority of doctors. But let's look at the long-term career of doctors. Do we think this is still protected outside the house? I'll say yes, for sure. Because all of the material of guilt is one that is firstly immaterial, given that you have to expend care to a lot of other patients. They're able to maximize their happiness from other patients. But also secondly, it is likely to be very temporary in nature. Note that doctors have to go through like thousands of patients in their lifetime. I argue that this one decision where they had to follow an ACD, given that you already have some alleviation from their guilt because you're following whatever the patient wanted in the first place, is likely to be reduced and temporary in nature. Panel, at the end of the day, we protect the sanctity of the dying. We protect the right of the individual to make a decision, given that they're incapacitated to make the decision on their deathbed. We protect the ability of individuals to preserve the dignity of their life, given that this is one that is unlikely to be afforded to a large number of people. Don't take away the ability of people to live the life the way they want to. Extremely proud to affirm.
Thank you, everyone, for an outstanding substantive portion of this grand final. Let's now move to the reply portion. Let's start first with the negative reply. Welcome back, Ritabrata. You're here.
Sorry, Mikey. Joel's just dropped out. They're rejoining now, so we just wait 1 second for Joel to rejoin.
No problem. Did Joel drop out? Oh, don't worry. We'll talk about that after.
Joel dropped out during your spiel. They should be back in the Zoom now.
Yeah, I am back. I caught everything that the third next said. I just dropped out during Mikey's transition.
Welcome back, Kuhan. Sorry, I also said Ritabrata. Wrong. Kuhan first.
Confirming if I'm visible, audible. Perfect. Okay. Starting my speech in 3, 2, 1. This reply is simple. I'm going to give you 3 technical flaws of team affirmative that already makes them lose this debate. And I'm also going to hammer it home on one other reason on why we win. First, on technical flaw. The first flaw of team affirmative is they centered the entire case on the assumption that ACD has to be instances where patients are dying only. We gave you a laundry list of examples and illustration to prove to you why we can have catharsis on our work, because oftentimes ACD is also taken by patients that are going to go through pain in the future. So they're making the decision right now. We explain why they signed off, or they meet attorneys to have like validation, psychologists to have validation, family consultation. All these are instances where they have the capacity to consent, they have not responded to. That means their case is at best marginal. But even in the instances where they are dying and they're making the decision that right now, We explain why their rationality is already impaired in these circumstances. We are sick, where your mental capacity to consent to anything right now is probably bad. It's worse now, where you don't have a say in what's going to happen to you later on. At least when your rationality is impaired and you have some level of say what's going to happen to you now, you can also weigh out the considerations that happen in those worst case. But the preliminary contribution to make in this debate is that they've been very inconsistent and they only deal with one part of the debate, wasn't charitable towards a large part of our case. Secondly, their only harm judged is guilt. Number one, guilt literally happens worse on your side because if the patient lives as the result of you overriding ACD, but you go through continuous amount of pain, that guilt is on you as a doctor for causing that particular pain to that person because they're not living a good life, but also financial capacity. What if that surgery costs a bomb to the family? They can't afford it to begin with. That guilt is far worse on their side. But number two, what about doctors abusing more individuals as a result of this precedence? This also brings more guilt towards patients and you as a result of continuing practices that are not in line with what you want. But thirdly, you cause more harm towards their families because they're already prepared with one outcome, but not overriding the outcome that might introduce a different implication that just goes through all this emotional baggage on their mind. Judge, what we need to take note of. Both sides got some repercussion. It could be the case that patients die in our side as a result of their judgment, but it could also be the case that they die as a result of the doctor's advice, as a result of dying in the surgery in their bed, or wrong advice, or a profit-driven advice by the doctors that lead to worse circumstances. So in the worst case, if they die in our world, at least it's weighted according to externalities, meaning the money and emotions your family go through, but also they're more prepared to accept decision. But if you're alive as a result of doctor overriding, what about your sustainable livelihood? What we need to take note of is life isn't a scientific definition of just living and breathing. It also weighs in the quality of life they're going through. And pain is incredibly subjective because you don't have epistemic access to know what a patient goes through. And if their subjective experience is one that is bad and detrimental, that is on you. So even in the worst case scenario, it's far better in our side when you actually consent. But the last flaw of team affirmative is they're incredibly unresponsive. We give nuanced material on why doctors are likely to abuse, why doctors are driven by profit, why medical science is one in which they always have mistakes, have lacuna, and we have no consensus towards what's the best objective decision. Their response is just doctors are the best. You can't just say doctors are best. If that inaccurate decision falls in the part of patients living a worst of life, I'm unclear why that's a principle that you ought to prioritize. Why do we win? Ultimately, we will have the clearest principle in the debate. Explain why the principle of autonomy should always supersede any form of malfeasance or beneficence principles that doctors or medical practitioners can be bad. We're also very clear in instances where doctors can be bad and where there's a lack of accountability measures by science. We explain why, number one, there can be cost accrued to medical science which patients cannot access. There can be lack of consensus of what the best decision is. Maybe one doctor says one good thing, another doctor says this is the best thing for you. We don't know what is right. But thirdly, science has erred before and made mistakes on how evidence to that is Vioxx, which is a painkiller, had to be reverted at a point in which they found out side effects later on. All of this means science can be wrong and you can't claim that it's the best. But it's also the case that doctors probably don't care about preserving lives, but are influenced by decisions of big pharma, hospitals, and what their respective clinic wants. It's oftentimes a business as well. And that's why it led to doctors prescribing drugs like OxyContin and Xanax during the opioid crisis that made worst of situations because of lobbying of pharmaceutical companies. If we're able to prove to you that doctors can be bad and there's a lacuna, at least the onus is given back to the people. You understand what's going through with your life and you've consented towards all the harms that come with it. And therefore, it's so clear, negative team. Proud to negate.
Thank you to the negative reply and the negative bench. To finish off this grand final, it's the affirmative reply. Welcome back, Ritabrata.
Hi, can you hear me? All right, starting in 3. Yeah, starting in 3, 2, 1. Locking yourself in an ACD and having no ability to change it later on. Or say, for example, doctors to override it, who technically be proved as a whole. Firstly, in terms of choice, and I think over here, it's upstream of, say, any pragmatic things that side negative talks about, because point at which they lock themselves into the ACD, because firstly, why you shouldn't, like why doctors should have the ability to override the choice. We told you essentially why these individuals have a greater amount of information at their disposal in terms of like exposure, or say, for example, the Hippocratic Oath and all of those things that are valid, which means the principle we said that you always delegate decisions to individuals who comparatively have greater amount of knowledge than you would ever be. They contest this, and this is the comparative that weighs out in terms of perhaps you have the information, you can talk with your family and consultation, etc. But if those things are valid, comparatively, you as an individual have less amount of information. This is because in terms of the deadlock breaker, we told you why you don't have access to your future preferences in terms of what is going to happen in the future, or in terms of how your circumstances are going to change at that particular instance. When you lock yourself into that ACD 20 years before, at that point of time, it becomes very difficult for you, or like it's impossible for you to change that. Then they said, and this is the only response that comes in op-whip, when they say ACDs can be changed over time, which is that literally buys into the principal concession that they should be subjected to be overridden. I think at that point of time, that's a huge principal concession that they make, which means at that point of time, we prove to you why doctors essentially inherently are in a better situation to make those choices. And at that point of time, these individuals comparatively aren't, because you cannot essentially decide in terms of what's going to happen like 10 years, 20 years down the line. Perhaps your circumstances can change. Perhaps you are in a situation to change your, or afford it financially that you weren't able to. This is not something that you can predetermine 10 years before. The only response that they have largely is to say, well, what about Jehovah's Witnesses who essentially want their lives to end in a certain way, or if you don't have money? The premise of choice means that you have access to alternate options. If you didn't have money anyway in the first place, then you were never in a position to make that choice in the first place, which is I don't feel they can push this burden, the extreme characterization of what happens if you don't have money at all. It's assumably that you have access to alternate options and you choose the trajectory where your life ends. Then they make this claim in terms of why doctors are likely to make bad decisions, and how does this compete with the material we presented. One, we told you why this reduces the autonomy that you have as an individual, and you're less likely to be dedicated and committed to your work, because particularly you feel you can't make a difference and you can't essentially make a change. They say that you can be lobbied by pharma companies and you can essentially be lobbied by external factors. But note the weighing for this argument. The point at which you feel that you're less important in the system, you're less able to exercise autonomy yourself, that is the point at which you're more subjected to external lobbying. That is the point at which when you reduce that ability and let yourself be lobbied by external factors such as pharma companies, etc. Which means, one, they don't solve that situation on their side of the house, but the very material that we presented in terms of you like taking that autonomy and onus on yourself means you're less likely to be influenced by external factors on our side of the house. And that is the point when you essentially get better decisions. All they do when they lose the sense of autonomy and when doctors feel that they essentially can't change the system in a meaningful way, that is the point at which all their worst harms in terms of being lobbied by pharma companies, providing drugs that can be detrimental to patients, like doing less effective medical care, and in general the quality of medical care reducing, happens more on their side of the house. Which means the situation gets even worse off that they go ahead and prove. Which means on our side, you doctors or medical professionals comparatively are in a better position, because at least they feel committed to their work, and at that point of time they can make better life-saving decisions at the end of the day. So that's why we win on the pragmatic. Just to conclude this, I think in the end, individuals have a greater amount of epistemic access to their present circumstances and preferences, and at that point of time you can't essentially consent or choose in terms of like what's going to happen to you in the future, because we told you why choices, circumstances are more likely to be subjective. What is objective in this round rather is this individual's ability to have access to that epistemic reality comparatively more, or individuals who essentially have this access more, such as doctors, who operate then in a better way in this present circumstance. That's the reason why you should be able to do this, and that is the reason why for at that instance doctors would be in a better situation to do this. That preserves comparatively autonomy more, it improves the medical system, and ensures that you get better quality of treatment. For those reasons, affirmative.
And that's that. Thanks so much everyone for the ESL Grand Final. That was an outstanding debate. The panel will now confer, and in the closing ceremony we'll come to a decision.